Okay, we are going to get started. Welcome, everyone. As you just heard, we are recording the program today. First, I'd like to introduce myself. I'm Robin Lerner. I am the Director of Community Engagement here at Charles E. Smith Life Communities. And for those of you who may not be familiar with us, we deliver quality care and meaningful experiences personally tailored to those we serve, no matter where they are in life's journey. Our full suite of care and services available on campus include independent living, assisted living, memory care, post-acute care, long-term care, and primary care with a focus on older adults at our Hirsch Health Center. If you'd like more information about our services, you can visit our website, smithlifecommunities.org. Before we go any further, I would like to introduce Jess Eyre from the Quran organization. She'll tell us a little bit more about herself and what the organization does. Thanks, Jess.
Thank you, Robin, so much for having us, and thank you for everyone who's attending today. My name is Jessica Eyre, and I am the Regional Resource Director in the state of Maryland for Caron Treatment Centers. Caron's main campus, and the one that houses one of our two older adult programs in Pennsylvania, is about 2 hours from the Bethesda, Maryland area, and we offer various programs across Caron's continuum, all of which specialize in drug and alcohol treatment. We have a second location down in Delray Beach, Florida, that also has a brand new older adult program as well. We're really excited to be here. Thank you so much for having us. And I'm going to share my information in the chat as well, because part of my role is to connect people who need treatment with Caron. So I can be your direct point of contact, cell phone, email, anything you need to assist with any patients that you think might need Caron's treatment. And I'll turn it back over to Robin to introduce our speakers today.
Thank you, Jess. And thanks for being here today. Just a few more quick things before we get started. I do want to thank our sponsors, Optum and Minkoff. We appreciate their support, and it's through their support that we're able to provide so many of these free educational programs that we do throughout the year. As I mentioned, as you were all coming onto the program, this program does qualify for 1 continuing education credit for social workers. You must be present for the entire program, and you need to be logged in with the same name and email address that you registered with. If you are using a different name and or email address, please throw that in the chat so we can keep record of that. We will be sending out a post-event email with a survey, which we ask that you complete in order to get your continuing education certificate. There will be a deadline on there and when you have to complete that survey by, so please pay attention to that. We are giving a little extra time this round because of the upcoming Passover holiday. I did mention that we are recording. Before we get started, I do want to introduce one of my colleagues, Kathleen McGinnis. Kathleen is the Director of Smith Life Home Care, and I invite Kathleen to say a few words.
Good morning, everyone. Thank you, Robin, and thank you for helping us bring this great program to our community here in Montgomery County and elsewhere. I see people from out of state as well. So I'm happy to be here. My name is Kathleen McGinnis. I'm the Director of Community Relations for Smith Life Home Care, which is an award-winning home care company that is also a sister company with Charles E. Smith Life Communities. We do serve older adults in Montgomery County and Washington, D.C., and have been doing so for more than 20 years in our partnership with Charles E. Smith Life Communities. So we help people age in place, wherever that may be, safely, whether it be their home or a hospital setting or a assisted living setting. Many people need additional support, and we can generally be available to families within 24 hours. I'll also put my contact information in the chat. I'm thrilled to see this program here because addiction in older adults is a pretty significant problem in this area and many areas in the country. And my connection with the Caron Treatment Center goes back to more than 27 years ago when I wasn't an older woman then, I was much younger. Anyways, Now I'm an older woman in recovery from addiction, and I just wanted to say that Care and Treatment Center was a valuable part of my journey and still is. They have excellent alumni programs in the Washington, D.C. area. And they also have a unique program, at least I don't know if they'll talk about it or not, but I found in Pennsylvania campus that was called Breakthrough, which was very helpful for people. Many women in recovery have significant issues with personal traumas. It kind of goes with the addiction issues. But they have a week-long program there in their Pennsylvania campus that I found extremely helpful towards my personal growth and towards solidifying my personal journey in recovery. So I'm going to get back in my lane of home care. That was just a personal input there. And just saying, as a member of this community for many, many years, I have also had a fair amount of experience with families and having issues with addiction in their homes. And I've been able to kind of walk them through the process, refer them to Karen, help provide companionship till they were able to get the right, all the right things in order for that person. So thank you all for allowing me to be on this program today. It's amazing to be here. And Smith Life Home Care can be reached at 301-816-5020. And our website is Smith, SMITH, lifehomecare.com. Please feel free to ask our staff for me personally if it's regarding this issue. And again, my name is Kathleen Mahoney McGinnis. We welcome all cultures on this campus. Thank you.
Thank you, Kathleen, and thanks for sharing all of that with us. That was very nice of you, and thanks for being here and for helping to put this program together. Without further ado, I am pleased to welcome our speakers today. First, Dr. Ming Wang is the Medical Director for the Older Adult Program, and Dr. Devin Dartrick is the Supervisor of Psychological Testing Services. Unfortunately, today, our third speaker, Diana Santiago, had a family emergency. She will not be joining us. First, Ming Wang is an addiction medicine physician and an associate medical director at Curran Treatment Centers. He oversees the detox and chronic pain programs and Curran's nursing staff and serves as the medical director for the Grandview and older adult programs. Dr. Devin Dartrick is the supervisor of psychological testing services. She draws from her extensive background in working with children, adults, and families from diverse backgrounds who have a wide range of mental and behavioral health concerns, including mood, anxiety, and substance use disorders. Thank you both for joining us today. I will turn the program over to you.
Hello, everyone. Happy to meet you all on Zoom here. My name is Dr. Wang. I'm the Associate Medical Director here at Karen, Pennsylvania, and I'm also the Medical Director of our Older Adult Program. I've been with Karen for, this is going on over 10 years now. And when I first arrived at Karen, we were taking care of older adults. And we were taking care of older adults the same way we were taking care of the general population. They were assimilated into the general milieu, the older adult men in the men's program, older adult women in the women's program, and so forth. And our organization here at Karen, we recognized a long time ago that to successfully treat the older adult population for addiction requires a certain unique infrastructure. Taking care of them requires a special skill set, and we also needed the infrastructure. So we created the Older Adult Program in 2014. initially was a renovated unit, which was a very, very effective unit. And then once we built the medical center here, the NEAC Medical Center, the older adult program moved into this building on the second floor where we're sitting right now. And the reason that we saw a need for specialized treatment for older adults is that older adults are special. They are unique in many, many different ways. So that's what Dr. Daltrick and I are here to talk about different aspects of the older adult care in addiction. So at the end of this presentation, all the participants should be able to recognize that the older adults is the fastest growing population requiring specialized substance use disorder treatment. The participants should also be able to understand the treatment components needed to provide effective treatment for the older adult, and be able to address the clinical needs needed for this population. Next. In this country,
yeah, you want to skip to the medical section.
I'm sorry. Yeah.
Yeah, she's got it.
Okay. Okay. Yeah, we're gonna there we go. I'm looking for my slides. The earlier ones, Diana's. So next. And next. So with the older adults comes in many different forms, as we all know, both from a medical standpoint, mental health standpoint, and physical standpoint. And here we have an example of someone who is an older adult now. And as you can see that this older adult is in rather good shape and has always been. Next. And so is this one. Edith was the holds the world record for weightlifting. And so I believe Edith is now into her late 70s, and she still sort of looked like this. And so these are examples of how that there are many variations to older adults, that not all are the same, and not all are debilitated and deconditioned, which is the population that we typically see here at Caron Treatment Center. Next. What I'm going to talk about, my background is addiction medicine. I'm a board certified addictionist. I'm also a board certified anesthesiologist, and I was a pediatric anesthesiologist. So I dealt with babies and very young children, especially in open heart settings. And in anesthesia, we are very mindful of the pharmacokinetics and pharmacodynamics in the human body. What basically pharmacodynamics and kinetics means is that what does a chemical substance do to the human body, and then what does the body do to that chemical substance? Okay, so this has to do with pharmacology. In order to effectively care for an older adult, whether it's in a typical medical setting like a hospital or addiction treatment center like Caron, we have to understand physiology and pharmacology of older adults. It makes a huge difference. And here at Caron Treatment Center, safety is forefront, is front and center. Next. We also have to be mindful of potential co-occurring medical issues in the older adults. Older adults typically comes with many co-occurring issues, and these are issues aside from their substance use. Older adults tend to come with more underlying medical issues such as heart issues, kidney issues, hypertension, lung disease, and central nervous system issues. And central nervous system is something like I like to spend some time on, because this is one aspect of older adults that is is often leads that older adult to our facility and to treatment centers. And also not on this slide is chronic pain issues. We do see a lot of older adults with long-term chronic pain issues that eventually lead them to coming to our facility because opioids are involved and prescribed by their physicians. Next. So in order to talk about the central nervous system, which is I'd like to spend some time on, the central nervous system essentially composes of brain and the spinal cord and all the peripheral nerves that stems from the spinal cord. And with any substances ingested, I'm not just talking about alcohol or mood-altering substances. I'm talking about any substances, any medications ingested that would require certain function of the brain, okay? And what we're seeing in front of us right now in this animation, in the red portion, that represents a brain cell, okay? And the yellow part component, that represents another brain cell. And what happens in the human brain is that regardless of what function is required, whether it's moving muscles, whether it's processing information, retaining information, whether it's seeing something or hearing something, all require a process of one cell in the brain talking to another cell, and so forth. And for example, if I want to make my finger move to grasp a pen, that requires the activation of a part of our brain called the motor cortex area on top of our brain. And in order for my fingers to finger muscles to contract and grab a pen, this process in front of us where one cell is sending a neurotransmitter across to the next cell, and then which leads to a propagation of more and more cells being activated, eventually leading to the muscles in my fingers to be contracted and grasping the pen. Okay, so this is important because when we talk about an older adult or any individuals consuming a mood-altering substances, whether that's alcohol or prescription medications, oftentimes this process occurs. And in the United States, we are talking about 3 primary substances that leads an older adult to coming to a facility like ours. Number 1 is still alcohol. Number 2 and 3 are prescription benzodiazepines, such as Valium, Xanax, Klonopin, things like that, and as well as prescription painkillers, opioids. And with chronic repetitive exposures to these substances, through a process similar to what we're looking at in front of us, there's an area in our brain called the mesolimbic system. It becomes adapted to that pattern of use of that alcohol or that prescription medications. And what happens after that is that after chronic exposure to these substances, the mesolimbic system, which is our midbrain, becomes adapted to that pattern of use. And soon after that, in the progressed stage of the disease, then another part of the brain called the prefrontal cortex, which is responsible for higher functioning of our brain, becomes affected. Next. So here's the brain, and the part of the brain that I was referring to, the mesolimbic system, is in the middle of that brain, okay? Where you see the purple circle and the purple line. And there's a bigger purple arrow that points up to the prefrontal cortex, which signifies that with repetitive exposure to mood-altering substances, the mesolimbic system, that midbrain, becomes adapted to that pattern of use and eventually involves the prefrontal cortex. So the mesolimbic system, the midbrain, is our primitive brain. It is a part of the brain that's responsible for our survival. It's that fight or flight area. So when we are threatened or our loved ones are threatened, the mesolimbic system becomes activated. And so we're in a hyperadrenergic state. So we become more hyper-aroused, we become more aggressive, we become, sometimes people say we become stronger and faster. You've heard stories of a young mother lifting a car off their child because their child got pinned under the car. Well, that's the activation of the mesolimbic system. So this area of the brain is responsible for survival, but it's also the area of the brain responsible for addiction. You could see that on this slide, there's an area called nucleus accumbens and amygdala. And this area of the brain also encodes information for pleasures and rewards. And so with alcohol use and mood-altering substance use, individuals usually consume those substances because it does something to them. It's often something rewarding or pleasurable. And so our mesolimbic system, especially the area below the mesolimbic system, the amygdala, it is very efficient in encoding those pleasurable and rewarding information, such as eating a delicious plate of food or eating dessert or having ice cream. Those are very pleasurable experiences. And so is drinking and using mood-altering substances because it changes the way that person feels, and it's often it's pleasurable and rewarding. After long periods of use, this area becomes adapted to it, and that need for the drink or that substance or that medications often becomes a life or death experience. Without it, the person feels that sense of impending doom, that everything's not okay, that I can't be okay until I take that and take the next drink or that next pill. Next. So this area, I like to call it the oh wow area. Anything that gives us that very pleasurable, oh my gosh, oh wow feeling, the mesolimbic system has something to do with it. And you saw just briefly a little while ago, dopamine, there it is. Dopamine is one of those neurotransmitters that becomes activated when our brain is exposed to a mood-altering substances that offers that person a certain rewards and pleasures. We have many neurotransmitters in our brain. Dopamine is perhaps the most familiar one to most people. It's that feel-good chemical, right? A runner who goes out for a run gets that runner's high, the dopamine level surges a little bit and he feels relaxation, that sense of well-being. And so that's dopamine. We have many other ones, such as norepinephrine, serotonin, glutamate, just depending on what function needs to happen. Next. So the prefrontal cortex area has to do with the higher functioning part of our brain. It's the executive functioning part. It provides us with good judgment and appropriate behavior. Next. So just more neurotransmitters in there. Glutamate, if dopamine is that feel-good chemical, that glutamate would be the feel-bad chemical. So they have many, these transmitters all have their various functions. Next. So the central nervous system the frontal lobe here is, and the cerebellar gray matter in particular, is very sensitive to to alcohol, especially in large quantities. We have different types of brain cells. Earlier on, I mentioned brain cells, but I didn't really talk about what type of brain cells, and we have many different kinds. And alcohol appears to cause quite a bit of damage to the type of cell called spiny neurons. And with the older adults, with heavy use of alcohol, there's an increase in the cortical cerebral spinal fluid in the gray and the white matter area. We would also see volume deficits in the anterior hippocampus, possibly resulting in something called the Korsakoff syndrome, which is a permanent memory loss. There's also reduced brain sugar metabolism, resulting in disruption of the neural integrity. So in other words, alcohol causes a lot of disturbances in the central nervous system, not only the actual destruction of certain cells, but also disrupts the sort of the chemical balance in our brain. There's also been noted to have low frontal lobe perfusion, resulting in cognitive and emotional changes as a result of prolonged heavy alcohol use. Next. So with older adults, once in a while, I do send people out to get a CT scan of the head because they've had a history of falls while intoxicated, and it was never evaluated in the emergency room. They did this intoxicated while in a blackout, and family's priority is to get them to a treatment facility and kind of bypass the hospital. So sometimes I have to send people out for CT of the head just to make sure the fall did not result in a subdural hematoma. And what often we would see in a CT scan of the head on older adult with heavy alcohol use, that we would see neuronal loss. So basically what the radiologists will report is the brain that appears smaller than usual, okay? And otherwise, nothing else is notable. And there's also overactivation of the NMDA receptor, in other words, upregulation, which may lead to more cell death. There's activation of microglia and astrocytes in brain tissue, which is more cells, which leads to aberrant signaling of neuroimmune system, leading to dysfunction of circuitry. So in other words, disruptions of these neuronal cells and their connection, basically you're disrupting the neural circuit. Our brain is like a big giant electric circuitry, and alcohol does wonders in disrupting the circuitry. It's kind of like pouring water onto an electric field, and it disrupts many things. Now, although many theories of cell destructions are out in the literature, the exact mechanism behind alcohol-induced neurotoxicity is still not very well understood. Next. So go back to the last one. So the last slide, we were talking about effects of alcohol on the central nervous system. And this slide right here talks about the effects of sedative hypnotics and opioids on the central nervous system. And older individuals who are taking prescription sedatives and painkillers are at an increased risk for falls. The sedative hypnotics includes the benzodiazepine that I mentioned earlier, Valium, Xanax, Klonopin, oftentimes prescribed to the older adults for anxiety and for sleep. And hypnotic includes the barbiturates. Sometimes barbiturates, even though it's an old one, barbiturates overall tend to be an older medication, are still prescribed to older adults, surprisingly. And when an older adult is being prescribed opioids, likely for their chronic pain conditions, eventually what we see is that they are eventually prescribed benzodiazepines. Opioids usually comes first, then benzodiazepine comes second. And I see this pattern over and over again over the years I've been at Caron. And the reason for that older adults tend to come with both of these substances prescribed to them is that opioids are addictive medications. The human body tends to develop tolerance to opioids. The older adults has a tendency to take their medication as prescribed by their physician. No more, no less. They're actually pretty good at that. They typically do not abuse their prescription medications. There lies the problem right there. Because with addictive medications that human body develops tolerance to, if an older individual is taking a prescribed opioid such as Percocet, as prescribed by their doctors for many years, if not decades, what happens is because of tolerance, they develop what's called interdose withdrawal. That means that their body requires more painkillers, but they're not taking more. And so the body is actually already going through withdrawal. Okay. Example to clarify that point would be a drinker who typically drinks 1 pint of vodka per day. Over years, his body requires more because of tolerance to alcohol. And if that person drink a little bit less than 1 pint of vodka per day, he potentially could go through significant alcohol withdrawal, if not a seizure, because he's drinking less. Okay, opioids and sedative hypnotics are the same. So when an older individual is possibly experiencing interdose opioid withdrawal, one of the symptoms that comes with opioid withdrawal is heightened anxiety, restlessness. They feel jittery, they can't sit still, they can't sleep. And so they go tell their doctor, I'm really nervous, jittery, anxious. So here, and I can't sleep. And they're prescribed benzodiazepines. And now they're on 2 substances coming to our facility. And with the especially the sedative hypnotics, the benzodiazepines and the barbiturates, they have a property where the person experienced what's called antegrade amnesia. Basically, it's a blackout. So after taking these medications, the brain has a difficult time encoding information. Okay, it's kind of like someone having a blackout from a night of heavy drinking. Not retrograde amnesia, but antegrade amnesia. And so if a person is drinking alcohol as well and taking prescription benzodiazepines, oftentimes the family notice that they're starting to get more and more forgetful. What is going on? Is this early sign of dementia? This is the question that we're often asked. I was just talking to a family yesterday regarding a potential lady who's coming to us. And the family, this is one of the first things that family recognized, that why is she so forgetful? She repeats herself, does not remember a conversation. And when I reviewed the medications with the family member yesterday, and sure enough, benzodiazepine was prescribed to her quite a while back for anxiety. And so this is antegrade amnesia. So oftentimes one of the reasons for one of the questions that family members have is their older adult loved one are becoming more forgetful. What is this? Is this early dementia? What are we looking at? And physicians and psychiatrists, they cannot determine the cause either. So Dr. Daughtry will touch on this a little bit more when she speaks, but this is often something that we do address. Some of the toxicities involved with sedative hypnotics and opioids is one of the primary ones, and the most significant one is potential for sedation and respiratory depression. And there's also obviously memory problems and psychomotor impairment. With older adults, the central nervous system, and we're talking about the brain, okay? Our brain has a covering on it, okay? This is called a blood-brain barrier, okay? When we're younger, that blood-brain barrier is intact, it's doing what it's supposed to do, keeping out certain substances, especially more water-soluble substances. As we get older, that blood-brain barrier kind of deteriorates a little bit. It ages too, just like the rest of our body. And so now that blood-brain barrier is more vulnerable to penetration of fat-soluble molecules. And most medications are fat-soluble. And so for the older adults with a little bit of breakdown of the blood-brain barrier, they are more vulnerable to any mood-altering substances, whether it's alcohol or especially prescription medications. So in other words, a little bit goes a long ways. It's very similar to a baby. In the old days, I used to tell my anesthesia residents, when you handle a baby or a young child, you got to think about their blood-brain barrier, because a little bit goes a long ways. Same thing with the older adults. Tolerance develops to most cognitive effects, but not all of the sedative agents produce the same type of or severity of the impairment. So in other words, benzodiazepines and opioids have very unpredictable and variable effect, especially on older adults. Next. So next, we're going to talk about the heart. Oftentimes when we, especially talking about alcohol, we always talk about the liver, but it's not just the liver that alcohol affects. It's every single cell in our body. The liver, the heart, the kidneys, brain, the muscles, everything. And so this is a little bit overboard right here. This is way overboard. I'm a cardiac anesthesiologist also, so that's why I put this in there. But basically, when the heart is affected, especially by alcohol, what happens with prolonged exposure to heavy alcohol use, the heart goes into what's called alcoholic cardiomyopathy. In other words, you all have heard of heart failure, right? So this is a form of heart failure. In order for our heart to effectively generate output, in other words, when our heart muscle squeezes, a huge portion of the blood get pushed out of the heart into the circulation, which on the very first line, cardiac output is equal to the heart rate times the stroke volume. So with alcoholic cardiomyopathy, is essentially a big floppy heart. That's the whole idea behind this. Okay, so the cardiac output diminishes, which would contribute to the impairment of the rest of the organs, because if the output is not adequate to the rest of the body, the brain suffers, the kidney suffers, the liver suffers, everything suffers. Next. Oh my gosh, this is another way over the top graph here. So again, this graph right here essentially shows what cardiac output looks like in someone that's normal versus not normal. Okay, let's skip this slide. So now we're moving on to the lungs. Lungs provides a movement of oxygen from outside of our body to the cells where it's needed as part of the fuel. Okay, so the part of the mechanism of respiration involves breathe in, breathe out, right? And this mechanism, this motion of taking a breath and blowing it out, again goes back to the brain. The brain controls that rhythm. It's the ventilator for the human body, and how the brain determines how fast to breathe, how deep to breathe, depending on the chemistry in the blood. In other words, the oxygen in the blood, the carbon dioxide in the blood, the acid base level in the blood. Okay, that's how our brain determines whether we should pick up our breathing and breathe a little bit faster or breathe a little bit deeper. Okay, so if we were taking a run outside, our muscles are generating a lot of acid, lactic acid, and carbon dioxide. So our brain switch the gear up a little bit. So we start to breathe faster, not only to take in more oxygen, but to blow out more carbon dioxide. So that's how our breathing is regulated. So the respiratory regulations governed by the chemoreceptors that detects the chemistry in the blood, at which time then the brain will regulate the rate and the depth of the breathing. Mood-altering substances, alcohol, sedatives, opioids, all interfere with that process. And one of the scariest things to see in an older adult is to expose them to potentially sedating agents and watch them fall asleep and their respiratory rate slow down. And then before you know it, they're not arousable. I've seen many of that, not just in anesthesia, but also in the setting of substance use as well. Because these substances directly impairs the mechanism in the central nervous system. Again, remembering that these mood-altering substances are highly fat-soluble, it crosses into the older adult brain very easily because of the highly penetrable blood-brain barrier, and now a little bit goes a long ways. Next. This next slides talk about muscles. I'm wondering if our audience here ever wonder why, or if you ever seen an older adult, and not just older adults, young people experience this too, where after they stop drinking, they could barely stand up. And while they're drinking, they appear just fine. They're walking around, they're moving around, and once they stop drinking, they can't even get out of bed. So this is what's called alcoholic myopathy. Alcohol, again, affects every single cell in our body, including muscles, and also not just the muscle cells itself, but also the protein synthesis required for muscle development. So muscle atrophy is a decrease in the mass of the muscles. It's not reduction in the muscle cells. It's decreasing in the mass of the muscles. This leads to muscle weakness. And since force required from the muscles, it's dependent on that mass. Neurogenic atrophy is caused by damage of nerves stimulating these muscles, but oftentimes with substance use such as alcohol or sedative, hypnotics, opioids, we're not talking about neurogenic atrophy. We're just talking about direct mechanism of this myopathy. And also, especially in older adults, not all the time, but oftentimes in older adult, when alcohol use is involved and or prescription medication use is involved, which may come with chronic pain condition. Oftentimes they're not very active, they're sedentary, they're just kind of laying around on the couch in bed, they're not eating very much, which leads to further deterioration of the skeletal muscle integrity. Downregulation of protein synthesis pathway has to do with as part of this mechanism. Next.
I think we have until 1.
Okay, to 1:30, I believe. 1. Jess, how much time do we have?
I think they said we only have until 1.
1. Okay, so let me move ahead a little bit, and so next slide. Next. So I'm going through many different parts of the organ. This is talking about the kidneys. We'll move on from there. And here's the liver. Okay, liver is a big one. Oftentimes, with especially the alcohol users, we do see very progressive liver disease, including liver cirrhosis, very progressive liver cirrhosis. And recently, I just referred someone for liver transplant, and that's how progressive state that patient get that we often see around here. And so let me keep moving forward here so I can get Dr. Daughtry going here. Keep going, Jess. Okay. So this is all about the liver. I don't want to spend way too much time talking about the liver because this is a very big topic here. But let me just stop right there, okay? And so the message to the audience is this, that older adults with addiction issues do comes with a very unique problems. The involvement of these organs are not necessarily unique to the older adults, but what's unique is their age and the changes in the organ system that may require specialized medical attention in order to keep them safe and treat them effectively. And so I want to leave the rest of the time to Dr. Daughtry because she's going to talk about the psychological aspects, including neurocognitive impairment. That's quite interesting that we see often here.
Hi, everyone. I'm Dr. Daughtry. I am the clinical psychologist on the older adult unit, and I also oversee our psychological testing services here at Caron, which does include neuropsych testing, which is a big part of what we do with our older adults here. Next slide. So in my role as a psychologist, I am looking primarily at any co-occurring disorders in our older adult population. You may have heard the term dual diagnosis, same thing as co-occurring disorders. This is an individual that's diagnosed with both a substance use disorder and a psychiatric disorder. Very common presentation. Generally speaking, 60 to 70% of individuals with addiction or with a substance use disorder also have a co-occurring psychiatric disorder. Most commonly, we see these as mood disorders, anxiety disorders, and also a lot of trauma disorders in our older adult population. We see the development of these substance use disorders as a way to self-medicate this co-occurring mental health concern that the patients have. And interestingly, sometimes that drug of choice, whatever they're using, whether it be alcohol or opiates or benzos, can really be an indication of the mental health issue that they're struggling with. So for example, opiates, not only are they going to treat chronic pain, but they can also energize depression in some people. Same thing with a stimulant. We see lots of benzodiazepine used to manage anxiety and depression, and alcohol, same thing, depression and anxiety to kind of numb that psychic pain. Next slide. So here are some of the common problems in older adults that have addiction. As I mentioned, self-medication leads to addiction and tolerance, and then all of the downstream medical effects that Dr. Wang talked about. But it's really the short-term solution to treat mental health. We routinely see in our patient population how a co-occurring issue or a psychiatric condition gets worse in the context of the substance they're using to treat that exact symptom. So it really becomes this vicious cycle where someone might feel depressed, lonely, they want to isolate, they drink more, and then it causes more loneliness, isolation, and depression. The substance use can also dramatically interfere with other medications they're taking. So for example, we have many older adults that are on SSRIs for antidepressants, but they're also drinking, which is going to interfere. Drinking a depressant is going to interfere with an antidepressant medication and make it less effective or not effective at all. There is a general stigma, a generational stigma, and really a great reservation for older adults to seek both mental health and substance use treatment. So that's definitely a challenge that we see in getting our older adults here into treatment. One of the primary ways that people come to us is through family involvement. It's really a spouse, oftentimes a son or a daughter who recognizes that something's wrong with their loved one, and that's how they get into treatment, rather than an individual that is coming to treatment without the suggestion of their family. And it's also just a challenge to have an older adult really understand both of these diagnoses. And a lot of what we do here is provide education for them to really understand what's going on. Older adults have a tendency to minimize their mental health symptoms. They might be guarded, less likely to disclose, particularly their trauma histories. And a big problem that we see here in our older adult population is cognitive impairment. Okay, next slide. We'll run through this slide very briefly, but generally speaking, mental health disorders and substance use disorders occur as this mix between biological and environmental factors. So there might be a biological predisposition to either a mental health diagnosis or substance use disorder, but then there's many other things that happen in our lives, that happen in our environment, that can really trigger both of those co-occurring issues. Next slide. So at Caron, we really take a integrative, multidisciplinary team approach. So Dr. Wang and I are just two of the teammates here, medical and psychology, but we have nursing staff, clinical staff, chronic pain services, including acupuncture, medical massage, physical therapy. We have a spirituality team. We have a family therapy team. So we really try to take an integrated approach with each patient to really treat the whole person. And I'm just going to focus on that part of that work, which is the psychological piece that I do as part of the team. So I start with every patient doing a thorough psychological interview, which includes gathering all the information here you see on the slide. And I won't bore you with reading all the bullet notes here, but you get this sense that this is, a thorough evaluation to really get a sense of what's going on with this patient, with more of a mental health focus rather than a medical focus. A big part of this is neurocognitive screening to see if all the basic cognitive functions that we expect one's brain to be able to do are intact or not. Next slide. One of the biggest components that I talk to our patients about, and other staff for that matter, is that just because someone has symptoms of a mental health diagnosis doesn't mean that they have the diagnosis. So for example, our patients come in with every symptom under the sun, and really time is the best way to tell what's going on. So there are lots of mental health symptoms associated with substance use, with substance withdrawal, what's called post-acute withdrawal symptoms. So we try to do our best to make a diagnosis, but we don't want to jump to a conclusion that someone does have a co-occurring mental health diagnosis when it might actually just be substance related. Next slide. And this is just some examples of that. So with those three main drug of choice categories that Dr. Wang talked about, there's all kinds of different symptoms, mental health presentations that we might see based on which substance they're going through withdrawal. And this post-acute withdrawal is what happens after the acute withdrawal phase. So once they're medically stable and not going through active withdrawal, there are these lingering post-acute withdrawal symptoms that can go on for weeks or months to varying degrees. Next slide. So as I mentioned, assessing cognitive impairment is a huge piece of what I do here on the older adult unit. About 50% or more, generally speaking, this is of all ages, entering substance use disorder treatment have some level of cognitive impairment. It might be mild, but they're not at their cognitive baseline when they come into treatment. This number is even higher with our older adults. And the big question is always, is this substance related? If I stop drinking, is my cognitive function going to return to baseline? And again, time is the best way for us to determine that. At the initial assessment, I use a brief cognitive screening measure called the Montreal Cognitive Assessment. It's really good at picking up cognitive impairment, even mild cognitive impairment. If that is abnormal, if that's below where we'd like it to be for a person's age, then we repeat the Montreal Cognitive Assessment in about 3 to 4 weeks. The neuropsychological research really shows us that the most improvement in the shortest amount of time that you're going to see following withdrawal is about 3 to 4 weeks after the person's last use. So we repeat the cognitive screening measure, and many times it bounces right back. It comes right back to where it should be, right within the normal range. There are other times when it doesn't, and most common areas of impairment at that point are in either visual spatial functioning, executive functioning, that prefrontal cortex that Dr. Wang was talking about, and also the hippocampus, where the memory center of the brain. So in that case, we then do more thorough, in-depth neuropsychological testing to get a good baseline of cognitive strengths and weaknesses in early sobriety that can really help us make recommendations for what level of care does this person need with their activities of daily living, their daily life when they leave here. Next slide. And this is just an overview of a lot of what I've said already, but digging in a little bit deeper on how we then treat the co-occurring issues once patients are here and they've been identified. So we are part of our interdisciplinary team here, providing a lot of different evidence-based treatments. So not only do we have individual therapy with both the counselors and with myself, but we do have cognitive behavioral therapy groups for anxiety and depression, trauma groups, which include psychoeducation groups and art therapy, as well as yoga. And then many individual evidence-based trauma treatments, including cognitive processing therapy for PTSD and EMDR for trauma treatment as well. We also have, psychiatrists on staff here that we will, treat co-occurring symptoms with safe, non-addictive medication. Next slide. All right, we did it. I think we're at 1 o'clock. So I understand there might be some questions coming in the chat that we can try to address.
Yeah, thank you both. That there's obviously a lot to go through on this, so I realize that you had to rush that a bit. That's a lot of information, and I mean, I found it super interesting. I think everyone else did too. If you have questions, please put them in the chat. I'm going to scroll back because I think there were a couple things that I may have missed. I know there was an early question about your organization working with insurance, and I don't remember the particulars of it, but do you work with insurance if someone comes to the organization for help?
We do. We have multiple different programs here on campus. Some of them are insurance-based, some of them are not. Primarily speaking, the older adult unit is more of a private pay unit, just given the level of care and resources that are used that go outside of what the insurance contract will cover. But we do have a few insurance beds on our older adult unit as well. So it's quite a mix.
Great. Other question, someone asked, does Cron offer initial family with patient to convince them that they need the program? I guess like an initial consultation of family and patient.
Yeah, you want to take that one?
Yeah, you're talking about referral to treatment, right?
Margie, if you want to chime in and give me a clarification on that.
Hi, thanks. Well, just thinking about when the family is really trying to convince the person that they really do need this type of program, do you all provide some kind of initial meeting? I guess you could call it a consultation to try to convince them?
Yeah, yes, we do that. And there are essentially 4 phases that I did not mention of older adult addiction treatment. It is a unique population, and oftentimes it's a challenge to even identify that whether the older adult has addiction issues or not. So 4 phases are identification, then referral to treatment, then the treatment portion, then the aftercare portion. And so identification is a challenge in itself, but once it's identified, whether through family members or healthcare providers, then referral to treatment could be pretty challenging too. And if needed, one of us, if not all of us, would get on the phone with the family or the patient themselves and talk to them a little bit about need for treatment, what that might look like. And oftentimes they're very scared. And so a conversation might just help reassure them that everything will be okay.
Mm-hmm.
Yes, we do that routinely. And that's the phone call I was referring to yesterday, talking to the family and the patient.
Okay, thank you.
Got it. I'm just looking back. I think there were a couple others, but I think you addressed them within the presentation. Does anybody else have a question that I didn't, that I missed or that was not addressed? If you can just pop that in there, that would be great. But I think we may have addressed everything else. Thank you both. This was a wonderful presentation. I really appreciate your time and that you shared your expertise with us. I did want to provide just a few very quick closing remarks. As a reminder, I know many of you had asked, we will be sharing this PowerPoint with you, and we will be sharing a link to the recording from this session. You will get a post-event email, which will have all of that information, along with the survey that you need to fill out for your continuing education credit. I did also want to mention, and Kathleen, thank you for posting that in the chat earlier, that we do have a program on March 30th, tomorrow, called Sip and Paint, which is for social workers and nurses. And if you are interested, you can call 301-816-5020, or you can email Jackson, Jackson, at ceslc.org to get more information. If you'd like to join, we do have a few spots available for that. Thank you all for joining us today. Again, thank you to the two for such a great presentation. Yes.
Excuse me, 1 second. There's one person who's asking about their question that was asked very early on. It says, as dementia progresses and the older adult gets older with alcohol abuse, does tolerance to benzodiazepines change? If the patient has been on benzos for decades with a history of difficult weaning, titrating, is there a point in dementia progression that the patient is more likely to respond positively to decreasing their dose, especially if other meds have been introduced since Risperdal and Remeron? Sorry for the bad pronunciation. Dr. Wang or?
Yeah, Dr. Dahltrig and I were just looking at that question. Tolerance, someone who's been on benzodiazepines for decades, they can respond very well to the weaning process. The human body is predictable in that way that yes, tolerance will develop, but that doesn't mean even after decades of benzodiazepine use on a daily basis, does not mean that weaning cannot be successful. I took care of an individual in our early older adult years. This gentleman was on benzodiazepine, to my best calculation and to his best calculation, almost 50 years continuously. And we were able to successfully wean him off in a very, very safe fashion, and he did well.
Great, thank you. Thanks, Kathleen. I totally missed that one. I think we've got all of them now. I posted a few pieces of information in the chat, our website for upcoming programs, the annual Sarah and Samuel J. Lessons Healthcare Symposium on May 11th, where we'll have continuing education credit available for nurses, social workers, and nursing home administrators. So I do realize that ideally we probably would have scheduled this for a little bit longer to cover all of your information. Thank you both so much. Thank you all for joining us. And we'll look forward to seeing everybody at one of our other upcoming programs. Have a great day. Thank you, Jess.
Thank you
All right,
all.
thank you so much for having us.